good afternoon, everybody, or good morning or good evening, depending on where you are in the world. Ryan or Paul, do you want me to start video or no?
Yes, I think if you can start video, that would be great. We only want people that are speaking to start the video. I probably should have done the same, so thank you.
Trying, apparently it's blocked. Anyway, why don't I just go? Look, I mean, I think maybe just the first thing to say is that often the humanitarian community, looks at a big intervention, let's say the West Africa Ebola outbreak, where I did some research on that afterwards, and we talk about lessons learned. And many of the lessons learned aren't really lessons learned, are they? I mean, saying that it's a lesson learned to engage with communities and talk with them, there's something a bit hollow about that kind of a justification for a lesson that's been learned over and over and over again. And I really think that a lot of the times when we talk about lessons learned, we're really talking about lessons that were ignored, lessons that were very well set out and sidestepped. And community engagement's a great one, because it's been a lesson learned in every major humanitarian intervention going back over the last 20 years. The second point I'd make maybe is just, look, obviously the coronavirus outbreak is quite unique and exceptional in some ways, and similar in others. And I think looking at lessons can get us on that path of path dependency and maybe not questioning them enough. And I think of lessons more as a proposition, something to be tested in a given environment. And one of the things I was thinking about when talking about lessons learned here is, what is the key difference? What are the similarities and what are the differences in terms of the way the coronavirus might impact in some of the countries where humanitarians work, in some of the lower income countries, things like that. And for me, one of the things would be to say to ourselves, what does it mean that the global North might not be able to respond in such a massive fashion, a massive influx of resources and expertise, the way we saw, for instance, in the West Africa Ebola outbreak. I think it's a pretty obvious question to start thinking about how that might be different here if aid money doesn't flow, if aid expertise doesn't flow. But I wanted to give an example of something a little bit different, and that is remittances. My colleague Laura Hammond over at SOAS recently blogged a piece with some others about remittances, and I hadn't thought about that. I was so busy thinking about how the aid system might be different that I hadn't thought about the fact that if remittances largely come from, let's say, the global North, that means the diaspora country, people from the places in certain countries that are affected by coronavirus living in the global North and not being able to send money back. What does that mean? What does that mean if they are households in crisis in places like the United States and the United Kingdom and can't do what we saw, for instance, in West Africa, where the Liberian diaspora and the Sierra Leonean diaspora were quite active? And the reason I say this is that most people don't realize it, but remittances to the 20 most fragile states constitute at least double, I forget what the exact figure is, but it's at least double of all aid. All foreign aid is less than remittances. And so it's an extraordinary source of stability, and in particular at moments of crisis. And I hadn't even thought about it because I was so busy worrying about, well, if the US government spends $6 trillion in the United States, is it going to have money to fund, agencies and like the WHO, like UNICEF, and also the humanitarian groups? So just an example of how we need to think a little bit beyond the box about how the crisis in the global North is affecting, will have an impact in the countries that will be soon to be affected. So I don't know. I'll shut up there, Paul, because I hope I'm still not the only one online, but please.
You are certainly not. Thank you. Thank you. I want to move to one or two other people. I'm going to have to ad-lib at this point because our presenters, other than Marc, are not. But I wanted to add on a little bit to what Marc was saying, and that is, I think a lot of people are looking at our most recent, of course, outbreak of Ebola, and in a conflict setting or humanitarian setting, such as the Kivus in DRC. and I wanted to perhaps bring up something. It's not by any means controversial, but what I'm interested is to hear about is the issue of quarantine and isolation and closing of borders. And what was clear in Ebola was that you're not, generally we say, let's not quarantine. And we saw what happened in Liberia when we quarantined a whole town. Let's not close borders. And despite WHO's admonishment for people not to actually do that, or countries not to do that, that is what is happening worldwide. And what was interesting to me was to look at the pathways, the way the two diseases, viruses actually transmit, and that there may be reasons, not maybe, there are reasons, unlike in Ebola or some of the hemorrhagic fevers, in these flu-like settings, flu-like, I know it's quite different, the coronavirus, but particularly with a very high transmission and with an area where that is there where you can transmit when you're symptomatic. What's become very clear is that there is not a one-size-fits-all in terms of should we quarantine, should we not quarantine, should countries close their borders, despite some of the economic settings, economic issues that are occurring. And so I found that to be an interesting lesson learned, because from looking at HIV in the past and looking at Ebola, it was very clear when you try to take a much more authoritarian approach and start closing down, forcing people to go into ETUs, as was occurring in DRC, we have found that people will go underground, and that the virus, or whichever the disease may be, will spread. That is not the same effect here. And we're finding that, one, many people are actually following the various orders, perhaps because of education, perhaps because of where it's occurring. Secondly, the other area, I think, lessons learned from my side is looking at how there generally has been and able to be an external surge. So looking at Ebola, or even in SARS, in some of the higher income countries, there's a surge of people. But here, because it has spread so quickly and there's a pandemic, I don't think in many situations we're going to be able to expect wherever people are, whether in a humanitarian setting, if it's in a camp or a non-camp setting, it feels like people who are affected, and then the governments themselves will be on their own in terms of, so for example, in the Rohingya, as we've talked about in the past, I think it may be unlikely that there's going to be a surge from the international community to be able to respond to a COVID epidemic in the Rohingya camps, because this is currently a pandemic. I'd like to move, if I may, and I'm going to put some, I see Karl may be online. So Karl, I don't know if you're online and able to speak.
Yes, I can.
Okay, wonderful. I've been ad-libbing while waiting for you, so I'm hoping that you can now take over.
Okay, sorry for the delay. We were on another link, and we experienced hacking online, which was terrible, insult and everything. So we had started our webinar on the other side with Sharon and Ngozi. So I hope Ngozi is going to be able to join us as well. If my colleague from Geneva, Ngozi, perfect, you're here. So what we could do is, if someone from Johns Hopkins could help me with the questions, that would be very helpful. My colleague in Geneva stayed on the other link, so I had to ask him to assist me. So my name is Karl Blanchet. I'm in charge of the Geneva Centre for Education and Research in Humanitarian Action, and I'm going to, we have the pleasure to have Sharon, Ngozi, and probably Marc Dubois online. So Sharon, can you briefly introduce yourself?
Thanks. I'm a medical anthropologist who's currently consulting with UNICEF C4D.
Thank you. Ngozi?
Thank you, Karl. I'm an infectious disease epidemiologist. I work on developing policy specifically for resource-constrained countries, and I'm with Chatham House at the moment. Thank you.
Excellent. So one of the topic for this, and Marc is here. Perfect. Marc?
Yes. I'm afraid everybody's already heard from me. My name is Marc Dubois. I am a consultant in the humanitarian field. I'm also a senior fellow at SOAS, the University of London.
Excellent. Thank you very much. So today's topic, so there's a second webinar of a long series. I suspect Paul talked about it. And this today we wanted to talk about, can we really learn from past outbreaks to be able to respond to the COVID-19 pandemic? And so we have invited some fantastic individuals and experts to talk about their own experience and to share that with us. So I've got a long list of questions I have prepared for them. And I wanted to talk about one of the most key important aspects. We talked a lot about that, and the three of you have documented that a lot during the West Africa, after the West Africa Ebola outbreak and the Congo one, talking about community engagement. And that was a very key missing or key gap in the response. Are we doing better this time, Sharon?
Well, we're recognizing the need for risk communications and community engagement earlier, which isn't to say that we're doing better. I think that there have been some important global capacities that have been developed around both social science and community engagement, the READY network being an example. But I think that we have to recognize that the core infrastructure for ensuring that community engagement is mainstreamed and is sort of streamlined into core national response capacities has been inconsistently developed on a country-by-country basis and remains inconsistently developed in humanitarian contexts as well. I also think that we need to recognize that, there isn't necessarily a direct overlap between whether or not we're talking about high-income countries and low or middle-income countries when we're talking about community engagement, right? So you have countries like Uganda that have extraordinarily well-developed community engagement response capacities for epidemic response in comparison to, say, countries like the United States, which have really robust public health and medical capacities, but are quite community engagement distant, which has created, I think, actually substantial limitations in terms of our ability to mount an effective response in a context where there's a high level of asymptomatic transmission. So I'll pause there, but basically I'll just say, we understand now that we need community engagement earlier, but we still haven't put into place, adequate, coordination, implementation, and resource mobilization around it to sort of make that realization real.
Right, and what kind of, concretely, community engagement, Ngozi, it's a huge buzzword. Community is already a term full of definitions and meanings, but what kind of form can that take in a COVID response, for example? Do you have some concrete examples from some of the countries? I know you're highly connected with Nigeria, and what kind of concrete measures can we put in place right now?
Yeah, thanks, Karl. I think your point that community has taken on this ambiguous term, it's something that we really need to remember, especially in this outbreak, because it's happening on a global level. And so community has kind of become lost. At least that's what I think. I think because of the experience in Ebola, a lot of West African countries have a better understanding of community beyond just, urban and rural or village versus, an apartment complex. Community can, in West Africa and throughout Africa, we have a very high level of weekly participation in religious institutions. And so really thinking about, what do we do with churches, with mosque, and how do we engage those communities? That's what's happening right now. I know Africa CDC is really trying right now to write context-specific guidance for these different communities. So non-health sector communities, thinking about informal settings, informal workplaces, thinking about hawkers versus, someone that would traditionally go to an office. So there's so many different ways that we can think about community. And I totally agree with what Sharon said about, there needs to be a different direction of learning when we're looking at community engagement, community trust, really, because every country is really struggling with the trust component of this outbreak response.
And Marc, do you think that, we have seen during the Ebola response quite a lot of mistrust vis-a-vis healthcare workers and as well the fear of going to hospitals for having fear of being infected. And it looks like we are in a very similar situation with the COVID. Is that correct?
Well, I mean, I think just 2 days ago in Abidjan, people from a certain quartier of town in the city, the capital city of Ivory Coast, attacked, you know, what was being built. It was a testing center. It wasn't even a center for treatment. I think it was just a place in the community where people could go and get tested, and they attacked it. And I think it just goes to, I think that's a perfect example of where somebody didn't communicate beforehand. And I think when Ngozi talked about mistrust, I think one of the lessons from the West Africa Ebola outbreak is, you know, we saw those pictures of the big billboard saying Ebola is real. And I think if you have to start with that point, that people do not trust what the central government is saying, then you have to know already that when you try and communicate, you know, with communities and engage with communities, it can't be, let's just ship somebody out from the central government to a community and tell them what to do. It's a completely different type of communication. I know Sharon can speak to that much better. I maybe just wanted to mention 2 quick things. I think as a humanitarian sector, we've tended to pigeonhole community engagement in terms of, oh, how do we get the messaging right? And I think when you start to look at the decisions that need to be taken around, for instance, quarantine and lockdown, community consent that's the whole difference there. Either you have a community that is as happened in Liberia, in the West Point area of quartier of Monrovia, also in Freetown. If you don't have consent, it's unenforceable, and it's just going to end up being a mess, right? A violent lockdown and oppression and things like that. So that's one area, and the other is ethics. We are talking about decisions in the future that are going to have to do with very scarce resources. And how do you take decisions like that without engaging with a community, rather than, even if they're very sound from a medical ethical perspective, you need to have the community engagement in those kinds of decisions. This isn't just about messaging. This is about the types of programs and the access to the programs that we're running and the types of measures that are being taken.
But we're probably not in the same situation as the Ebola outbreak. The scale is very different. And that's the question for Sharon with this one. The scale is very, very different. And you're talking about it is important to get a consent. I mean, I don't know how it happens to, Marc, you're probably in the UK now, but I don't think we got any consent after this political situation on a lockdown. So how can we get this kind of engagement, or either some kind of co-agreement on what needs to be done? We are talking about very important political decisions that are going to have huge economic impact on many, many communities. A lockdown in some of the countries, like refugee camps, but some of the countries' rural areas, not going to the market, is going to put into poverty a lot of communities. How do we deal with that, combining a political decision, a public health measure, and community engagement? Sharon?
It's an important question, right? And I think that in order to think about this question properly, we need to reframe how it is that we're thinking about community engagement. At present, when we're thinking about community engagement in the context of this conversation, we're still thinking about community engagement as sort of involving going into the communities, telling people what it is that you need them to do in terms of behavior change, and trying to procure some sort of consent, right? Exactly as Marc said. I think that what we need to do is actually take a step back and remember that what's important about community engagement actually is the process as much as the outcome, right? And a key part of the process is actually engaging with local communities in order to identify needs, right? And if you identify what the needs are, how the community identifies its own needs in order to be able to deliver consent, you can put into place sort of the policy and enabling conditions that will enable communities to then provide consent in order to participate in these sort of conditions. But I think that we also need to recognize that, regardless of what political, legislative, procedural decisions are being made on high, communities and individuals always have the opportunity to dissent, right? All they have to do at this point is walk out their door in most contexts, right? Most people who are participating in social distancing on a mass scale are doing so as voluntarily, right? In compliance with policy. Just because the policy is there doesn't necessarily mean that people are going to follow it, right? So the fact that, so in spaces where you see this kind of, voluntary consent happening. It's because the enabling conditions are, for the most part, being put into place or were already in place. Now, we need to make sure that that process is happening for all communities in all places, because I think that we also need to, I hope that over the course of the conversation, we'll dive further into what you're saying about sort of the ethical implications of kind of looking at the trade-off between economic costs and sort of mortality that's associated with this particular epidemic, because it's very, very troubling, and it's gaining a lot of traction. I'll stop there.
Yeah, okay, let's talk about that. So it made me think about, you're absolutely right. So this pandemic is relies very much on collective behavior. And you're absolutely right. So we all receive strong messages from ministries of health and WHO on what to do. But the success of these prevention measures, Ngozi, probably rely on collective behavior. And we have learned a lot during the previous outbreak on that, on how to make it happen. What I fear is that some of the groups, and again, I'm going back to the refugee camp situation, I probably do not have received the same level of information than the rest of the population. I'm here, I'm talking about urban settlements or remote areas that probably do not have access to the same level of information. And that's a key challenge, right? Ngozi?
Yeah, I mean, I do think a challenge is not having access to information, but I'm not sure if that is the primary challenge right now. If you look at, you know, cities like Johannesburg or Lagos, or heavily populated cities, you know, very densely populated cities that have slums, it's not so much of not getting the information, but not having the information tailored to their situation, right? What I've been hearing a lot is, even in these difficult situations where there is no running water, we're still telling people to wash their hands for 20 seconds. And if I like what Sharon said about enabling conditions, if we're not giving people the entities, the equipment, the resources that they need in order to comply with social distancing, then we're just wasting our breath. And then we're also going to lead to future distrust of the government or the public health entity, because people are going to feel like, you know, other people or other communities are looking at them and saying, like, it's your fault that, you know, COVID-19 was able, or the virus was able to propagate in our community because you didn't stay home and you didn't do this. I think there are some really good examples of governments that are providing the resources they need and really looking out for the most vulnerable populations economically as well as health-wise. I think Rwanda is a good example of, you know, providing food to households that are underneath a certain poverty threshold. Also, South Africa has actually brought in huge water tanks to some of these townships. They've been building water tanks. Going back to Rwanda again, they've had these mobile, you know, hand washing centers. I think it does become much more difficult when you're thinking about refugee settlements, but it's not impossible. I think one thing that we have to do during this outbreak is to be innovative, especially in these areas where it's densely populated. People are very poor. People are battling other infections and other diseases. We have to be innovative and have targeted messaging. There are groups, as Sharon said, there are different communities that can stay at home, that can work from home, whether it be Uganda or Abuja or Cape Town. There are different communities that can do so, so they need to do so. In other places, how can we innovate, you know, doing ground markings that are 6 feet apart or 2 meters apart when you go to a market or you're standing in a queue somewhere. We need to be innovative.
Absolutely. So I think we are very clear on the most effective prevention measures. I mean, you have listed a few between hand washing, social distancing, protecting the most vulnerable. But what I hear from you, and Marc, you can tell me a little bit more about that, is we need some program adaptation or some adjustment to the local context, and either to make sure that there are local capacities and resources to deliver these kind of prevention measures, or to create them or to adapt the measures. What is a solution for the humanitarian organizations wanting to contribute to the COVID response, Marc?
I mean, I think, you know, when you say we have the measures to try and prevent that, I think a lot of that is theory. We have the measures that seem to work. Look, what worked in China doesn't even work here. You know, there's people in London wandering all around. It will be different in every country. And I think that last week's program was very interesting in that way. Basically just saying that, look, given the density and the numbers and the capacity of the health system, what does it mean to flatten a curve so that, for instance, the national health system here in London, it can handle it versus a country with, you know, 24 ventilators in the entire country. So I think we're not talking about adaptation and innovation. We really need to think out of the box. I think that the discussion last week was very interesting in that way. I think that when I see WHO and IASC and I see some of these guidelines going down, they look exactly like good, sensible guidelines written by people in Geneva and New York. But how do you really adapt them into the situation on the ground? I think one of the ways is you don't just ask communities what their needs are. You ask them what their ideas are. I think people in West Africa during the Ebola outbreak had ideas about how to monitor in their own communities the way in which people were walking around and interacting. I think people have ideas about this, and I think you need to bring them in. The second thing I would say is a lot of the way we think about this is sort of the negative adaptation. Okay, we've got this model in the north, and now we have to adapt it down to the global south. And I think building on what Ngozi just talked about, what about positive adaptation? I mean, we have communities that are communities as opposed to countries that are, you know, have been reduced down to all of us individuals, you know, in a much different way. How do you build on community involvement? How do you build on the fact that people still talk and know and share with their neighbors? All those kinds of things. I think you need to think about them. And I think you also need to think about them in negative ways. Ngozi just talked about, you know, in a lot of urban capitals, it's not that the poor are spread around, it's that they are, the spatial dynamics of where they are, you know, they're in an urban slum that's very dense, and we have gated communities. And I'm very worried about the way in which some of this just turns into a cordon sanitaire, right? The way in which the colonial empire used to protect the white communities, and now it's not going to be about white and black, it's going to be about lower class and working class and the poor. And what does that mean? And I think the real fear here is that, you know, a measure that's coercive is simply being adopted because this is what it looks like. This is what leadership looks like. Look, I'm taking these steps, but if there's no way of you know, mitigating the harsh, you know, the harsh consequences on people and their livelihoods, I think then you have to go back to the Syracuse principles and ask, well, can you take that measure if you can't mitigate the extreme you know, harm it might do to, in particular, to certain segments of society?
And Ngozi, would you like to add something to it?
Yeah, I really loved what Marc just said. And I was remembering when we were responding to Ebola in Guinea, I remember having these conversations with the communities, and they were, you know, it was kind of a negotiation, but it really brought dignity to the whole situation. And I think right now what we're seeing is just dignity being stripped away from so many people. And there's just so long that people are actually going to allow that to happen to them. In particular in Guinea, we negotiated about when certain high-risk households could go to the farm. Like they were saying, you know, we have to do farming, we have to go there every morning. And we had this kind of schedule when it came to contact tracing and monitoring. And it just became very friendly, right? Like, you know, you not allow people, but you ensure that people are doing what they need to be respected in their communities, to provide for their family. But you also have the public health measures that have to be in place, as Marc said, according to the situation. So I think just in imputing dignity when we're talking about public health measures, no matter where we are, but especially in those areas, countries, cities where we have large, poor and marginalized societies, that needs to be brought to the forefront of the conversation as well.
And specifically these days when we talk about the risk of actually increasing inequities in the system. So I think one of the key lessons from the COVID pandemic already is that the inequities are going to increase in many, many countries because social safety nets are not there, are not in place everywhere. So it's going to be very hard to mitigate the reduction of inequities in some of the aspects. So bringing back dignity makes a lot of sense and needs to be put in place. A lot of the questions are, I'm just trying to combine some of my questions plus the one I receive on the chat on social distancing or quarantine in very dense populations. And of course, there's a key question for all of us working in refugee camps, working in urban settlements. And maybe the response or the answer can come from some local initiatives. Sharon, what do you think?
I think that that's the right way to go. And I also think that we need to sort of ask ourselves, like, what is the flip side of not trying to implement social distancing in these kinds of settings, right? Which is something that's very much on the table in public discussions, right? So, I mean, I think that in order for us to kind of consider, right, the importance of implementing social distancing initiatives that are really drawing on local creativity and local answers and local solutions in these kinds of contexts, we need to recognize that the alternative is not implementing social distancing and creating conditions in these contexts that will lead to an enormous amount of excess mortality that will then also create a whole other set of incredibly high risk and volatile conditions that could then continue to lead to all kinds of worsening situations, right? It's not like the trade-off is between sort of maintaining economic stability versus implementing social distancing. It's, you know, trying to maintain economic stability, seeing a vast increase in overall morbidity and mortality resulting from COVID-19, destabilizing the entire population, or putting as many resources as we can into implementing social distancing. Now, the technical way, like, how are we going to do community engagement in a context of social distancing in a way that keeps community engagement activities from contributing to the spread of infection is a challenging question that we haven't yet come to an answer to, like, on, frankly. Like, there needs to be like a good, hard think about how it is that we're going to do community engagement in a context of social distancing, in a context of asymptomatic transmission in a way that doesn't make matters worse. But at the same time, that doesn't mean that we need to take this off the table as a tool. It's not viable, it's not ethical, and it's not going to lead to the kind of anticipated outcomes that everybody thinks is going to happen in terms of the trade-off.
Mm-hmm, mm-hmm. So, Ngozi, so we mentioned the inequities, but as well there's a question about received on the chat on stigmatization. There's a lot of stigmatization. We have seen stigmatization on infected patients, but as well on healthcare workers. But let's not talk about violence as such, but stigmatization is something we need to resolve and integrate into the response. And we have seen that in West Africa and Congo as well. And what kind of solutions could be adapted to the COVID pandemic?
Well, one thing that I think has been really absent so far are people who have recovered really sharing their experiences. I'm starting to hear it a bit more, specifically out of North America. But for a while, there was like a huge silence of those who have actually recovered. And when you're only hearing every day about, you know, increasing deaths, more cases, then it does sound that it sounds like it's a life sentence. Whereas that we all know that a majority of the cases will be mild. There are, you know, 20% would be, well, approximately 20% would be severe. And then within that, about 4 to 5% would need hospitalization and critical care. So I think that, you know, really talking about the distribution of severity when it comes to how it impacts individuals is important. Individuals, not just the most severe, not just the ones that require hospitalization, and, you know, thankfully they recover, not only them sharing their stories, but other people as well, people who have mild symptoms. The reason why I think it's important is it will reduce a stigma because it will make this more normalized. With West Africa, a lot of Ebola survivors, at least there was an effort to really bring together the stories of Ebola survivors. Also, there was a lot of efforts that still continue in West Africa as well as in DRC with education, especially education tied to the evolving information that we get from different scientific studies. So, you know, understanding that Ebola could be, even when you are a survivor, you could transmit it sexually, you know, that talking about that in a normalized, not panicked way is one way to reduce stigma. So those are some potential solutions.
And I would like to continue, and the question is for the three of you. Ngozi, you have published a lot of studies and you have generated a lot of evidence on all these outbreaks. And the question is, can we really learn from the past outbreaks? And I wonder how to make sure that all this knowledge generated from past experience can be really taken by first responders and by governments, and how should we do that?
So I think I'll answer kind of in two ways. One with general population and health workers, and then two with government. I'm heartened when I see the lessons learned and how, you know, health workers and public health specialists are reacting post an outbreak. You know, we saw in Nigeria, for example, they're learning from all the work they've been doing with polio, the consistent response to Lassa fever and monkeypox. All of that experience is not just thrown out the window when there's a new outbreak. And I'm very proud and excited to see what Nigeria's CDC is doing. For the countries that were affected by SARS, I mean, we've seen, like in Hong Kong, Singapore, South Korea, those countries, they were ready for COVID-19, you know, and they were able to put measures in place very quickly, educate their societies. And I think that's what also really excites me, is that the population, the societies themselves, if they've gone through all of this, if they're communicated to not just during an outbreak, but in between as well, they're also ready to take on like the mantle to respond individually. So that makes a big difference. Where I see less penetration of lessons learned is when it comes to governments. I mean, I've written some on, you know, lessons learned from Ebola, but a lot of it had questions or exhortations for governments to invest more in health systems. I feel like this is just a repeated, you know, chorus, is invest more in health systems. Prevention costs less than treatment or less than response, but I'm not seeing it happen. Not just, I see it a little bit when it comes to some multilateral organizations, but not at the country level, especially throughout countries in sub-Saharan Africa. You know, they came together in the early 2000s and signed the Abuja Accord that a certain percentage of their GDP would be contributed to health. And I don't think any country has actually achieved that. So I'm not sure what we can do to make sure that governments are not so reactive, or are more reactive, meaning reactive with investments, not just with these heavy-handed measures during an outbreak. Maybe this is big enough to see some real change, but I'm not sure.
Mm-hmm. But in a way, Marc, it's normal that we do not learn. I mean, we are in a very different situation, different type of virus, different type of world, and compared to a few years back, and there are many questions we still do not have answer from or about. What do you think? So I'm not surprised.
I spoke a little bit about lessons learned before, while you were still having the technical issues. You know, one of the things I think what Ngozi just talked about is the way in which, for instance, professional communities seem to learn lessons. This medicine works, that medicine works. Doesn't work much quicker than political communities, but also much quicker than the humanitarian sector. And I think, you know, if you look, for instance, at this issue of community engagement, why is it that we all agree it's a good thing and need to do it, and yet as a sector we can't do it? And the answer is that our theory of change is wrong. Just to borrow that kind of consultant word, the theory of change is that if we provide information to people, they will change their behavior, and that doesn't always work. We need to dig a lot deeper into the way in which we are structured as a sector. And I want to maybe just make a small point. You know, yes, all around the world, very few nations have invested enough in public health infrastructure. And that was one of the lessons coming out of the Ebola outbreak. We need to build healthcare systems, not reinforce a global fire brigade of humanitarians and global health security experts. And yet, look at where the money in it's the sexy thing to have your emergency response team. You know, I'm part of that humanitarian community, and I think we need to look at ourselves as part of a model that's the wrong model. The global fire brigade is the wrong model. And this is the epidemic that proves it, because we're all busy fighting fires at home. Well, when the firehouse catches on fire, they're not coming to your house. Mm-hmm. And I just think we need to think about this and the role we play in providing an excuse for not investing in healthcare in these countries, because we can do it very fast. We'll be there, we'll surge, all of that. I don't think we're going to change politics. I think we can look at our own role and maybe try and change that.
I've got 1 minute left, and that's my last question to Sharon. So to go back to ethics, I do think as well that not many lessons can be learned, because all the ethical challenges we have now are very, very new, or some are very new, in terms of scale, in terms of nature. Is that correct?
No, I mean, I disagree. I mean, I think that actually the ethical challenges that we're confronting are very similar to the ethical challenges that we always confront in the context of epidemics. They're just hitting new populations that aren't used to having these ethics raised, right? So, I mean, we're still talking about the constraints on civil liberties. We're still talking about people making cost-benefit analyses about the value of human life. We're still talking about whether or not we're learning fundamental lessons about sort of who's important as a target of medical attention, public health attention, and informational attention, and who isn't, right? We're still talking about, you know, sort of basic, you know, rights to privacy, rights to information. It's just, you know, I think that basically what's happening is that, you know, high-income countries are getting a taste of what sort of all countries have been dealing with in the context of epidemic response. But I do just sort of want to say that I think we just need to think really carefully about the fact that a really important way that we can be moving quickly now towards addressing some of these core gaps is by, once again, trying to integrate social science into the core of epidemic response. I mean, I think that one of the most minimal things that we could do is we have to shift the framework of both policy and epidemiology from an individual actor model to sort of a minimal epidemiological unit, which in many cases is the household, in some cases is the neighborhood, in some cases is the canton, right? And we need to be able to shift our framework on a context by context basis from an individual actor model to these like micro models of sort of, you know, social groups and social networks, because that is the most powerful sort of minimal unit of our capacity for response and prevention. So
thank you very much to you three. We have to stop here. We're on Swiss time. Thank you, Sharon, Shanku, and thank you very much, Ngozi. Thank you very much, Marc. Thank you. I just remind you that next week we're going to have Michel Gaillard from IRC to talk to us about program prioritization and adaptation in the times of COVID-19. I remind you that this webinar has been recorded and will be available on social media and by email, thanks to the Ready team. Thank you very much to all, and talk to you soon. Bye-bye.